Welcome to the Home Circle Bromley podcast, where we share the voices and stories of those often unheard, our housebound community. In today's episode, we're joined by someone who has been an integral part of our lives and local surgeries. He has been serving the population of Bromley for many years. Him and his team played a monumental role during the toughest times of COVID 19, and they still have continued till this day. They look after those who are housebound and unwell. It is my immense pleasure to welcome Yoven, the senior clinician of Rapid Response Team of Bromley Healthcare. We will be talking about the challenges faced by housebound individuals, the role of community care, and what it really means to support people in the comfort of their own home. So let's get started. Yoven, welcome to Home Circle Bromley.
Hi there, good afternoon. Thank you for the warm welcome.
It's my pleasure to have you on our podcast, and thank you for giving us your time.
No problems, anytime.
Jovan, can you tell us about your role in the rapid response team and how long you've been doing this work?
So my current role in Rapid Response, so I'm the service lead for the team. I've been in Rapid Response now for around 10 years, 10, 11 years. I've been in my role as service lead now for maybe 3 to 4 years. So the current role is not only making sure that the team remains operational 7 days a week, 365 days a year, but also managing the team, supporting the team and helping them develop into more senior clinicians clinically, broaden their scope of practice, helping those that are hoping to become advanced clinical practitioners and become independent prescribers themselves to then further help the community around. So hopefully one day go and manage their own teams and take on departments and hopefully push the community forwards. My actual clinical work as an ACP, so an advanced clinical practitioner, I started background as a physiotherapist. Went back to university to study to become an advanced clinical practitioner. This sort of gives me a little bit more of a broader scope of practice, which allows me to see a wider variety of patients, a wider variety of conditions, and sort of help manage to keep them at home. And the whole aim is to avoid hospital admission.
So, you've been working for the last 10 years in the Bromley Healthcare, looking after the housebound community in particular. What originally inspired you to work in the rapid response team?
Truthfully, it was a matter of chance at the time initially. I was just starting off in the industry in NHS, and was going where the work took me, to be honest. I always preferred the work in the community. Doing placements in the hospital, and in clinics sometimes wasn't always as pleasant, and the community was sort of where I preferred and felt like I excelled more. And the opportunity came along for me to work for Bromley's rapid response team under Bromley Healthcare. And since being in that team, I've worked with a number of doctors, nurses, physios, occupational therapists, paramedics, and a lot of those members have then gone on to become advanced clinical practitioners, which is where my interest peaked for going in that direction. But yeah, truthfully, it was just at the time a matter of chance. Thank God it's worked out well for me, and it's been very rewarding, the work that we've done over the last 10, 11 years in the community.
Yes. And for those who are unfamiliar, what exactly does the rapid response team does?
So rapid response, our main aim is hospital avoidance. The aim is to be able to get to patients' homes within a 2-hour response. The types of patients that we see are all housebound patients. Currently, these are for 18-year-old and above. And these are for patients who have deteriorated, and have become acutely unwell. This could be because of a long-term condition, which has now moved into a more of an acute phase, or actually this could be something completely new. A lot of the type of regular situations we would see often are mainly your chest infections, your urine infections, acute confusion, skin infections like cellulitis as well. But we do also have call outs for things like constipation, diarrhea, vomiting, dehydration. And part of the rapid response service also provides a falls pickup service. This is also based on a 2-hour response. So we've worked well with the London Ambulance Service to basically create a criteria where they can refer to us those patients who are deemed over a phone call anyway for a triage to be uninjured or have minor injuries, where the patient is alert and conscious and safe for us to arrive and assist them off the floor. And that's helped to alleviate the pressures off of LAS and A&Es as well.
What I understand is that you basically are looking after housebound people who are getting quite unwell and perhaps need to be seen quite quickly. And hence, you've got this quick turnover of 2 hours. This is a window period that you see the patients. Now, how do you coordinate the care quickly across the teams? You receive a call from the GP, and then you have to coordinate between the social care, the district nurses, the physiotherapist, phlebotomist. How does that happen?
It's communication, and it's years of a lot of people that have come before me's work that has been put into things like this to build the processes and the policies that have got us to where we are. But communication is the biggest key. We have built a lot of good working relationships with primary care, with the other teams in the community as well, so that we are able to lean on them to call them. For instance, with the GP surgeries, we have access to bypass numbers, which means that when we do need to contact them, we aren't waiting in queues. And a lot of GPs, bless them, are happy to give us their personal private numbers. So we have even faster access to speak to the GPs when we need to discuss a management plan or get treatment in for the patient as quickly as possible. I should have mentioned initially, actually, in terms of referrals as well, we do take referrals from now absolutely everyone in the community. So that can be any Bromley healthcare service. GPs, as you know, we take from London Ambulance Service 111. We also take referrals directly from St. Christopher's Hospice and care agencies, care homes, and nursing homes. And we now also take self-referrals from patients that we've seen and discharged within the last 2 weeks, which we're hoping in the future will open up. But just back to your question, with regards to the communication, we have direct numbers. So if we did need an urgent physio or an OT to come in, or district nurse, all of these referrals and systems are all put in place. We have a great team of administrators who are there constantly for us to get these referrals on, get the referrals allocated to the right clinicians. Yeah, and most days it runs smoothly.
What, in your opinion, are some of the most common challenges faced by housebound patients that others might not realize?
I think with the housebound patients, for those that don't have anyone at home, um, it can be a very isolated and lonely place. If you are living on your own and don't have family close by or friends, for those that can manage their own personal care, their meals, but they have someone deliver their food, they're often not seeing or having human contact for days on days until potentially weekends when a family member or a friend may be off work and are able to come over. For those that are, for instance, unable to care for themselves, it is just waiting for carers to come in, who, and again, that's for them, sometimes it's a stranger who they're not sure is in their home. And again, that's the only sort of human contact they're having for long periods of time. And unfortunately, some of the older population, for those that have communication impairment, communication as well, not being able to at least have a conversation or be heard from people from different backgrounds. I think all of that feeds into a lot of mental health struggles, which I don't think the housebound community, the older population, really voice as often as they probably should, or they're probably not self-recognizing those changes themselves, which is why when they do have that human contact from a carer or from a clinician, it's always important for us when we go in, even as a rapid response, going in for the acute situation, to try and pick up what else is going on in the home, because it may have been a long while since someone has actually had a look at the environment. Is it cluttered? Is there any safeguarding elements there? And raise those as quickly as possible. But I think one of the other huge issues is the lack of mobility If you are housebound and you're not using muscles and you're not standing, your body very quickly deteriorates. Muscles get weak very quickly, and to get those muscles back, it takes a lot of effort. They do come back, but it requires a lot of intervention. And if their mental health and their motivation is lacking, it's where we meet a lot of barriers and a lot of challenges to try and push past that. But I think the mental health issues then lead to a lot of the sitting down for long periods of time. And I mean, they talk about sitting being the new smoking, in that muscles deteriorating, that then reduces their independence and it becomes more of a reliance on others again around them, which then feeds more into a dependency and a vulnerability. It's just a cycle that I see that happens, and often it's just not picked up early enough. Uh,
Hmm.
yeah, which is the sad truth sometimes.
Yes, I was reading research, and the statistics have shown that more than 23 million adults in UK in 2022 reported to feel lonely. Now,
Really.
it's a huge number,
Mm.
and if we focus on loneliness and housebound patients, how do you see loneliness can impact health of a housebound person?
I think as we've touched briefly in that, being lonely and being isolated from the world, you can almost not feel like you're part of the world or part of society. I think for myself, I feel like I maybe don't have much to contribute. Is life over? Is this sort of all that I have left to give if I'm housebound and that severely isolated? I think it's a dark place for when those small thoughts start to happen and you've got no one around you to pull you out of it. It becomes a very slippery road. And as mentioned, it just becomes a cycle which then leads to poor mental health, which then leads to reduced mobility, a lack of maybe care for themselves as well, not picking up when the body's deteriorating quick enough or feeling the
Yes.
need to reach out, and also not knowing how to reach out. We're in now a time where things have changed a lot in the community and in the world compared to 5, 10 years ago. And for some of these housebound patients, they've been housebound for 10, 15, 20 years. And the services that are there, if they've been that isolated, they won't know what's out there. They won't know how to access that. They don't have the technology, or they have difficulties managing and using the technology that we now have and those resources. And I think eventually they will just turn away from the world because they'll see there is no other solution.
Yeah,
Yeah.
absolutely. And somehow, the approach towards life becomes very different when you are housebound. If I have to give an example of the people that I have observed or I have lived with who have been
Mm.
housebound, they would actually lose the focus on the diet. So perhaps, that attention and detail is not even given to the diet. And that also contributes to the
Yes.
general health challenges. So,
Yeah.
as much as we have housebound people, also have um, housebound carers of the housebound people.
Hmm.
And they are also affected directly or indirectly. What are your thoughts? What role do carers play when you visit, and what challenges do they often express to you?
I think their role, as mentioned, they are often the ones seeing the housebound patients more than anyone else. I think their role is one of the most important, not just for the hard work they're doing in providing the care that the patients require, but being the first ones on that front line to notice changes. And the number of referrals we do get from care agencies and carers, or often it's a family member that's called in to say it's a carer that's picked this up, and they're just calling on behalf of what the carers told them. And the nice thing about some of the carers who I've seen some really amazing relationships build between carers and the patients as well. They get to know them, and they can sense when something isn't right. The amount of conversations I've had where they're like, they're unable to give me much of a history apart from they don't they're not themselves. Something's different. Something's off. Uh, but it's something, and it's picking up as early as possible. I know the challenges from the care agency side and the carers is that they often don't get enough time to do the job they're doing. There's the rushing around from one to the other, and there's a lot of stress and strain on the care industry itself.
How about, Yoven, the role of the carers who are actually the relationships as well? For example, a wife, a daughter, a husband, a
Oh, yeah.
son, who are the full-time carers. How are they affected? And is there anything that you feel of through your experience you believe that can be done differently for them?
So I think the difficulties with family and friends sometimes becoming carers for their loved ones is the relationship changes, and you see a lot of like the son or daughter almost becoming a bit more like the parent, and it creates a lot of tension, and it's why the focus on having a plan and a management plan and a society built around the patient, with the patient in the center, involved in everything, is important. You can see that family members care truly for their loved ones and feel sometimes they're trying to protect the patient, but that's where often it can be a bit of a conflict of interest. It gets very difficult to sometimes separate the two. I think, and you hear more and more now about carer breakdown and loved ones that are struggling because they don't get a break. They don't get that ease of pressure. It's a 24/7 job because the nights can be just or more difficult than the days. And often they're not sure who to turn to either because they probably never thought that they may be in that situation themselves. So I think platforms like what you're building now is hopefully going to be a massive boost and benefit to not just the patients, but yes, the carers and those around in the future.
Yaman, how can a housebound person can be referred to you?
So the majority of referrals come through their GP surgery. But as I said, we take referrals from everywhere in that if a patient, a carer, next of kin, power of attorney, whoever it is, identifies a change or a concern, a worry, they can call either their GP, they can call 111, who can also refer directly into us. If they have a carer, they can speak to their carer. The carer can liaise with their care manager, and if felt appropriate, they can call us. The one thing we try to advertise is that we will take a call from anyone, even if it is just to be able to give some signposting or some advice. But referrals where we can accept a referral to actually come out and see you will need to be through a GP, through 111, or if you're under an organization like St. where patients are able to contact St. Christopher's first, lay that information or the concerns. St. Christopher's will then give us a call and discuss that with us. Now, in emergency situations, so this isn't to say not to call 999 if you need to. At the end of the day, if you feel you need to call 999, you still make that call. We've done work with the control rooms at LAS, so they have criteria and they will triage the call. And if they don't feel an ambulance is needed, they will refer to rapid response. They are able to de-escalate that call from an ambulance to rapid response, so we can get out there just as quickly to do an assessment. But that is based obviously on the triage, and also with some of the referrals where, and a lot of patients don't want to go to hospital. They don't want to be in A&E longer at a time, and the trouble difficulties that are going on there. Having an ambulance come out doesn't now always mean that you're going into a hospital 100%. We are also doing a lot of work with the London Ambulance Service to try and avoid that admission. So again, they can be stepped back down into the community, into rapid response and the other urgent community response services that we have under our umbrella.
Are there any myths or misconceptions about housebound individuals that you think should be corrected?
I think a lot of the things are for that there is no more contribution that can be given from a housebound patient potentially, and the thought that they are isolated and may feel that they have nothing left to offer. I think it's a myth that they can't give back or they can't still keep giving. They've spent years of giving to the community and to the country. That should not stop. And I just think it's a myth in that I have great conversations with housebound patients. The stories, they keep a lot of us clinicians going during the day, moments that have happened during the day that can make you smile, human contact, light. Your light is always shining. It's nothing that will be dimmed until your last breath is taken. There is always something that you can offer to the community, even if it is a learning that we can take. A lot of the work that we do is it's easy to look at something at the end when we're building projects and or we've sent a patient to hospital, for instance, we're looking at things in hindsight. They have that hindsight memory with them. They've been through the journey. They know what it's like further along the line. And that's the information that we need now to be able to put in the right structures and services. And for those that have the decisions of where funding goes, it's that information we need. So really what I can say is please don't think your time is over and that you have nothing to contribute.
Beautiful words. If you have to sum up your working in the rapid response team and you have to tell us one lesson that working with rapid response team has taught you about
Mhm.
life generally, what would it be?
I think it just touches back on the message from previous in that all life is important. The kind of connection you have can be had with anyone. I think when I started in rapid response, I was still very young, did not have much connection with people from all different backgrounds, different conditions. I think rapid response has opened my eyes a lot more now to the truth of what's going on in homes, the houses that we drive past every day and don't know what's going on inside them. And it's very rewarding to work in rapid response. When I first started as a physio, my thoughts were always to go into a sport background. Within a few years, that did change very quickly. The rewarding work of being able to keep someone out of hospital, to help keep a couple together for as long as possible is, yeah, it's a very rewarding job. And within rapid response to see the growth of everyone in the team as well developing. Yeah, it's very rewarding.
Yoven, thank you so much for your time tonight, and thank you for joining us and sharing your heartfelt insights. It's clear that the work of rapid response team goes far beyond medicine. It's about dignity, humanity, community, and goodwill. If today's episode resonated with you, please share it with someone who can benefit. Until next time, stay connected, stay kind. Thank you.